Thank you so much, Dr. Sujoy, for such a warm introduction. And it's always a pleasure to be here and seeing this work by day being carried on year after year consistently, because that is what matters, to keep going over time consistently and now reaching more and more people. And it's absolutely commendable. I will be talking today on the topic of type 1 diabetes in India, challenges, and all the topic was challenges. I just added a word solutions, and I will be going through some very broad level thoughts because to go in depth would take a long time. So all the pictures in this presentation are used with permission. So what do we want in a person living with type 1 diabetes? We want them to have access to a positive ecosystem of medical care and psychosocial support. And I see a lot of good work happening in day, and this is the focus that we are all looking at. Across the country, across the globe, but we face so many challenges. Is it really so much to ask for that a person in a democratic country cannot have these things? But we have 5 basic components. We want early diagnosis, we want awareness, we want access to qualified healthcare, we want ultimately a continuous and affordable insulin and monitoring. These supplies are necessary. And then there is a self-management via structured diabetes education and technology. This is a basic requirement, and that is going to make children empowered citizens of the country living with type 1 diabetes. But where are we today? Now, this is the type 1 diabetes index. It is quoted everywhere, but it is also a shock kind of a thing. It also jerks us out of our sombre when we are not looking at numbers, which tells us that we lost more than 9 lakh children over last few years because they did not have access to basic medical care. It also tells us that an average lifespan currently in India is being lost by 40 years, which is just a lifespan of 38 to 40 years with type 1 diabetes, which would have been an average of 70, which is a national average approximately. So just access to insulin and strips would have changed that, and we are missing out. So I don't want to go into these numbers. They are depressing, but the only reason we need to know these is that it's time to take action and look at it very, very in a focused way. So a given for some is an aspiration for others. These both are children coming to Udan, and one can afford, they have a little pouch with a pump in it, and look at the other child who just walks from the hospital and has no clue what to do. So, but this country, the society is for both of them, and hence the challenges come at many levels. So I'm going to talk about the problems, local solution and national solutions, and wherever you can fit yourself in, that will be a great way to go about it. So we wanted awareness and early diagnosis. Why is it a problem? We have illiteracy, we have a lot of myths, we don't have dialogue easily, and the GP is unaware. So what can we do is exactly what you're doing today, like day programs. This is the kind of thing. We need lots of advocacy program. It's not enough. Lot is happening, but we need newspaper articles, radio talks by local doctors in your own town, in your own village. It's time to go there. All NGOs need to go beyond full guns to the last mile. All the T1D leaders, which are doing a good job today, but it has to go locally across the country. We still have NGOs centered in the metros coming together, but we have to go to the last mile because every child who comes to me from a village tells me there were 5 who lost their life. So a basic GP has to be made aware. At a national level, we need a structured advocacy program. Things have better. This is better than what used to be. Yet, we do not have a program where a GP would be made aware. We do not have a national media coverage. We do not have programs in schools. So these are the things, ASHA worker, Anganwadi worker. So wherever you are, please work towards these goals. If you have connects with the government, this is where to go. Like I think Bengal is doing a great job. You have now in district hospitals, but that is not what is happening across the globe, and yet not across the entire Bengal. So we need to do it everywhere. Imagine a person not having access to qualified healthcare professional because we don't have enough in numbers. We cannot have a pediatric endocrinologist looking at every child. That we do not have updated current guidelines. Now they are coming up. We have now lots of, for example, from ISPE, from ISPAD, from national guidelines, from RSSDI, but they still have to be updated, very practical, be able to reach the last mile. So lots of CMEs, lots of local bodies which can create their own culturally sensitive guidelines, keep updating through newsletters. Pharma support can be taken to create awareness amongst doctors. Centers of excellence have been created across the country with pharma support, but maybe it is time we do it through the national government bodies, and that is where it will work and it will remain permanent. Training programs for doctors, there has to be some incentive. Why will they learn if they're going to get only a few children with diabetes? They don't have that many. Again, certified courses, presence in conference has improved. Like everywhere now, there is at least one talk on type 1 diabetes, but we want it to be even much more. So training people is very important. Of course, this is a bottom line. We want affordable insulin and monitoring, not just insulin, both. We know we can also go to the generic stores, look at the prices there. Today, we have worked out that generic glargine available in the government stores can be around 350 rupees. Strip can come down to a 7 rupee. This is what is currently available. Regular insulin at 75. But still, we would love to have a government policy where every state can give free insulin, inclusion in school health program, inclusion in NCD clinics. They have just entered the government policy, yet they need to go to every state, and we need a government registry. So supplies is our must. Then we have to have structured education. This is what you are doing today in day. We need one-on-one education. We need group education. Problem is we don't have enough educators. You're creating them. Cheryl is here. Shubha is here. I think this is wonderful what you're doing. But we still need so many more. We need so many more. So what did we do? We are in a rural area. We don't have qualified educators. We created our own. We created our own curriculum. We created the mothers. We created coaches, right? So something needs to be done, but we need more and more certified courses, please. And we need state programs because they need to get employment. Why would you become an educator if you're not going to get employment? And we need a very good resource library in every language, in every state. Everyone can learn. It's our job to teach them. So if all these challenges can be overcome, like this little Shraddha, she lives in a village, has no money, but she can count carbs and balance her plate. These another very important thing which can help is 24/7 helplines and peer group support. India is really coming up with lots of peer group activities happening. We need them to be more focused, and we need them to go to the last mile. It's not just one elite niche group. We need every child in every village to be able to reach out to us. This is my Usha who lives in a village, that's her home, and this is how she stores her insulin. Okay, there is a challenge, but there is a solution. So if we could get even intermediate care to every child, we would add a significant number of years to their life. So we can refer to the low resource setting guidelines and modify our treatment accordingly. Please do not forget that when we are seeing a person with type 1 diabetes, there are so many social determinants of health, and we need to look into them. I'll just go through it very quickly for want of time, but I want everyone to focus that consider these when giving a treatment. There's no point in giving a prescription of basal bolus insulin, monitoring, etc., if we don't know what is going at the background as a social determinant. So Ruhi, they thought the child should just die. Usha lives in a 25 square feet room with everyone. What can she do? This mother is absolutely illiterate. She was clueless how to go. Sanika was not getting married. Everyone, there was so much of stigma. Sanchita fathers doesn't earn, but yet she learned how to take care of her food. Young people, because of their condition, sometimes hide at work. So there is stigma and losing a job. That is another thing we need to address. Raju, this little boy who had come, they just kept on being admitted till they came here. Now, currently, he's doing very well. And they live in a remote village. There's no support. There's no doctor who understands insulin. They ask her, what is this? What is a keto strip? She knows more than the doctor in her village. So my last slide is the power of medicine for all of us who are physicians, educators, the entire team. And I will quote Dr. Rudolph Virchow in saying that we have an obligation to point out the problems and to attempt at least the theoretical solutions so that they translate into practical solutions. We are the natural attorneys of the poor. So there are challenges. There are lots of solutions. We are way better than 25 years back where we started, but we have a long way to go. Thank you so much.